Next, we have Dr. Mitchell Rosenthal from the National Council on Alcoholism and Drug Dependence. Dr. Rosenthal.
Governor, thank you, and thank you for your inspired leadership and passionate leadership. I think it has been very, very helpful. As Deputy Chairman of the National Council on Alcoholism and Drug Dependence, it is a privilege for me to share with the Commission the experience of our organization's affiliates that serve more than 90 cities and towns throughout the country. As a psychiatrist and the founder of Phoenix House, I've been treating addiction for more than half a century. At the Rosenthal Center for Addiction Studies, which I now head, we have been tracking the opioid addiction epidemic and assessing efforts to contain it. What our affiliates report and the frightening statistics of the CDC confirm is that the addiction crisis of today is likely to be the most deadly drug epidemic in this nation's history. We are engulfed in a perfect storm of disabling forces: the drug trade on the dark web, the availability of hyperpotent synthetic opioids, and the despair that prevails in small towns and cities where the factories are closed, the stores on Main Street are empty, and the mall that replaced them is closing too. The crisis is not only a threat to life, killing close to 60,000 a year and sharply raising the death rate for Americans in the prime of their life. It is also tearing at the social fabric of the nation and spreading a dark cloud of fear, frustration, and anger over cities, suburbs, and rural areas that had been relatively untouched by drug abuse before. And let me be blunt. Today, there is not nearly enough drug treatment capacity in America to help most of the victims of the epidemic. I am particularly concerned about the lack of long-term treatment and the treatment necessary to repair lives that have been shattered by addiction. Faced with the ferocious escalation of opioid addiction, NCADD affiliates have mounted programs of awareness, prevention, counseling, and referral for populations far more heterogeneous than any they'd ever seen before. For today, everyone is at risk, and every family prey to loss. Most terrifying is the reality that nothing we're doing today has been able to halt the spread of opioid addiction. Controlling the prescription opioid medication has not done so. Prescription monitoring programs, strict limits on the number of pills physicians can prescribe, and the CDC pain management guidelines seem to have capped usage of prescribed opioid medications. But overdose deaths from heroin and highly potent synthetics like fentanyl have gone through the roof, especially with young adults. Equipping first responders with naloxone, the overdose reversal medication, is a key feature in just about every community's response. But while the medication can avert an overdose fatality, there's no guarantee that the life that's been saved from one overdose will survive the next one. Most troubling to the NCADD affiliates is the difficulty they have in finding referrals for treatment. Adequate treatment resources are scarce, and there's enormous disparity between one state and another in treatment and prevention services that are available. In large measure, it is the states that determine what and where treatment and prevention services are delivered, but they look to the federal government for much of the funding. I'd like to point out three areas that I hope you'll thoughtfully consider. The most obvious of these is the future of Medicaid. Under the American Health Care Act, as passed by the House of Representatives, 14 million of today's Medicaid patients will be uninsured by the start of 2020. And some 30% of Medicaid patients today are being treated for substance abuse and mental health issue. A second concern is the rapid proliferation of medically assisted treatment programs without the use of counseling and behavioral therapies. Bear in mind that the key word in medically assisted treatment is assisted, for the practice is designed to employ medications in combination with counseling and behavioral therapies. The goal is not just to change the drugs one is taking, but to change you and your way of life. Often lost in the rush to get buprenorphine medication to as many patients as possible are the behavioral components that are needed. My third concern is for the needs of the most vulnerable and needful substance abusers. These are the men and women with few social or economic resources whose addiction has proven most disabling. Essential to their recovery is long-term residential treatment of a kind that makes possible a new level of self-awareness and the acquisition of social and vocational skills, along with the sense of self-worth and responsibility that are the bedrock of sustained recovery. These programs like Integrity House, Phoenix House, Samaritan Daytop, Odyssey, and Delancey Street are just such good examples. Few states today, though, have any long-term residential treatment of the type mentioned. What we see all too frequently for those most vulnerable, addicts fortunate enough to find treatment services, is a disastrous pattern of serial admissions to short-term programs. The pattern may start with an overdose and rescue, followed by detoxification, then a short period of residential treatment, and return to the community. A pause, and then the same sequence is repeated again and again. In so many tragic cases, the end comes with a final overdose. If the Commission does nothing else, I would hope your report recommends the expansion of true long-term treatment that lasts as long as needed. It will actually save money by reducing the number of multiple admissions, and it will truly save lives rather than today's practice that so often amounts to postponing death. I'd like to end, though, with a hopeful story, if I could. There was a young woman several years ago, African-American, who got deeply into drugs and was on the streets of the Bronx. There was a young boy in New Jersey who ended up on the streets. They both, through different mechanisms, ended up in Phoenix House and were there for 2 years, then went to community college. She, Sheila, was a year ahead of Michael. She finished community college and went to Harvard Divinity School. Michael, a year later, finished, and Sheila said to Michael, "Why don't you think about Harvard Divinity School?" He went to Harvard Divinity School, went back to New York, worked at the Innocence Project and some other places, and then applied to Harvard Law School. He went to Harvard Law School, graduated, and is now practicing at a white shoe firm in Manhattan. I saw them both within the last 2 weeks. There was a wonderful graduation of one of the programs at St. John the Divine, and there was Sheila in uniform. It was very touching. I saw Michael 2 days ago at a board meeting of Phoenix House, where he is now a board member. Treatment works, and we just have to provide it smartly. Thank you.
Thank you, Doctor. Thank you very much for that story as well, and for your testimony.